Hi, Dr. Donald Geriatric here. We're going to discuss part 2 of geriatric assessment. Our topics today are how to approach the physical exam with older adults. We also want to focus on both functional assessment elements and then also to talk about tools to conduct rapid geriatric assessment, as well as embedding geriatric assessments and management into primary care, focused around what we call the 4 M's. And we'll briefly talk about acute functional declines. So some of the key elements of a physical exam for older adults includes orthostasis, taking blood pressure supine and then upright. Oftentimes older adults don't complain of lightheadedness and still have substantial drops in blood pressure that predispose them to falls. We also want to establish their baseline temperature. It's so important to know if somebody has, let's say, a 97 Fahrenheit baseline temperature, because in the future, if they develop a 99.5 temperature, that could represent fever. We also want to remember that heart rate may not change significantly in the older adult, even if they're not beta blocked, but surely if they are beta blocked, there may be a blunting of the heart rate response, which is significant in terms of measuring orthostasis or responding to acute illnesses such as infection. So a lot of times people with febrile responses or hypoxemia will have tachycardia, but you may not see that in the older adult. So we always have to be reminded of the basic aging physiology as it relates to the driving force behind heart rate variability. We also want to use, I use a 50-foot walk to test ambulatory pulse oximetry. A lot of times individuals will get short-winded and you find out that they desaturate their oxygen levels as a consequence of walking. So we talked about temperature, and then gait speed is another key element of the physical exam. As we mentioned earlier, anybody that ambulates less than 1 meter per second with usual walking speed is considered at risk for falls, future cognitive impairment, hospitalization. So we want to cover these different elements of vision, hearing, and nutrition, and what the approach is for them. So certainly vision can be very simply screened with a Snellen chart. They're always performance-based type screening. It would be good to ask the patient to read something from either a newspaper or magazine. And then, like I say, to use vision screening with both corrective lenses and without. And I just want to make a point that we'll discuss later about fall prevention, is that there is new evidence that suggests that individuals that wear bifocals may not be good if they have a fall history because the vision gets disrupted by the trifocals or the bifocals. In terms of hearing, certainly looking for cerumen impaction is required in geriatric assessment. Referral for auditory testing would occur if somebody acknowledges some hearing loss or if they failed the whisper test. Okay, so that's you're 2 feet behind the person so they can't see your lips moving or read your lips, and then you ask them to repeat what you've said. In terms of nutritional status, you want to look for temporal wasting, which good example here where the temporal lobe is hollowed out. It may represent, you see that in anorexia as well as failure to thrive syndrome in older adults. You want to look at the BMI, ascertain whether they have low BMI as well as high BMI, and importantly to identify whether they've had more than 5% weight loss in the past half year. In terms of the neurologic exam, some elements that I like to add for geriatric assessment are frontal release signs. So you can see in this picture the snout reflex, but also you can have the glabellar reflex where you tap on the lower forehead, and if the individual does not extinguish blinking, then that's a positive frontal release sign. And of course, the third frontal release sign is the grasp reflex, which you typically don't see in the older adults unless they have some really significant frontal lobe damage. I also check for cogwheeling, both arms. Sometimes you have asymmetric cogwheeling due to a ipsilateral stroke. You also can, for people that complain of dizziness, lightheadedness, is do the Hall-Dix-Pike maneuver, which is represented in the right cartoon on this slide. And then, of course, part of the neurologic exam is to examine cognition in various domains, with the main representation of memory loss being loss of executive function. So that leads to evaluation of mentation. Typically in older adults, we examine both cognition, their memory capabilities, as well as their reasoning. Sometimes we'll include decisional making capacity as part of that assessment. And there are tools for decisional making capacity. We won't go into those today. But also as part of the mentation, we want to examine whether they have depressive symptoms and or anxiety. So as it turns out, older adults have more anxiety than they have depression. So doing regular routine screening for these different kinds of mentation issues is very important for geriatric assessment. So the reason we do cognitive assessment in geriatrics on a routine basis is that most people don't complain of memory loss and who may have memory loss. And some of that memory loss may be minimal cognitive impairment, or it may be frank dementia. They often don't report falls and accidents. And sometimes they'll defer a lot of questions to a spouse or family member. That in itself, if somebody says, oh, ask her, could be an important clue that they may have memory impairment. So anytime an older adult in your clinic defers questions that you ask directly of them, that it could be a good indicator of dementia. So what do we have for cognitive assessment? Again, these are all based on performance measurements. The easiest one and very sensitive and very specific is the mini Cog test. So that basically, you have the individual repeat 3 words, and then they do the clock draw test, and then you ask them to recall those 3 words. And remember that the 3 words always have to be different categories. So you can do something like apple, clock, flag, or apple, car, flag, something that has 3 different categories that have no relationship with one another. And the other important point to make is that when you have them draw the clock, it should be something like 10 after 11 o'clock. You want the hands on opposite sides of the clock, because if they have asymmetry in their cognitive impairment, you'll be able to identify that through the dual hemisphere testing by a clock draw where the hands are placed at opposite ends. And then I want to mention that if the mini-Cog test is screened positive by an abnormal clock draw or not being able to remember the 3 words, you then can proceed to a more definitive cognitive testing exam. We use the St. Louis University Mental Status Exam. It's gained increasing popularity because it's equivalent to what we call the MOCA, Montreal Cognitive Assessment Test, and the Mini Mental Status Exam. But its popularity is that it's for free, where the other 2 examinations have proprietary rights, and there's a charge for using those in a non-educational setting. So everybody's pretty much migrated to the Slums test. This assesses different elements of memory, executive function, abstract thinking, attention span, calculation, and visual spatial skills. So it turns out that visual spatial skills are one of the first components of cognition that fail with Alzheimer's disease. So that's always important to remember. So just have some representative clocks. You can see how people distort the clocks. The smaller the clock, the more likely they might have something like Lewy body dementia. So you can really tell a lot from how they draw the clocks. And sometimes it's very surprising to the patient themselves that they're not able to draw a clock. And then also, I just want to mention that sometimes you have the smart aleck who won't draw the clock but give you a digital clock version. So however that goes in your clinical assessment, it's important for them to show that they can actually draw an analog clock. So I mentioned the Slums Exam. So this is the St. Louis University Mental Status Exam, and you can see the different elements here of questions that they ask. This does not take very long. I think the longest part is question 11 here, which is a short story about Jack and Jill who live in Chicago, and there's several questions associated with recitation of that story. So it's a 30-point scoring. I just want to point out that if you're less than high school educated, you get a little bit of a bonus point so if you score lower, it's less representative of the cutoffs for cognitive impairment. So in terms of psychological assessment, I think really the PHQ-2 is probably the quickest way to identify possible depression. If that's screen positive, you can move to the PHQ-9. And this just shows that as the score increases, the positive predictive value increases with the higher score. In terms of social assessment, there's a variety of tools that are available, but generally these are asked as questions that entail things like spirituality. I often ask folks if they're church going, and if they said, well, I was, but I don't go anymore to church, that could be an indicator of change in functional status, either cognitively or physical functionality. And then also asking what their social support system is, who they would turn to in times of crisis. Also, as part of the social assessment, if there is an established caregiver, you want to try and figure out whether there's any caregiver burnout. It turns that the Alzheimer's Association has a pretty good tool for assessing caregiver burnout. And then you also want to ask if they have any financial concerns, which down lower on the list is the question of elder mistreatment. You can ask individuals if they've had any other money stolen or taken or misused. And also you can ask them in terms of safety, how do they feel? Are they fearful? Are they afraid of anything, of anyone? Okay, so sometimes you can find out some interesting things. I had a cognitively impaired older adult from when I was in North Carolina. When I asked him about, was there anything he was afraid of? And he said, oh, yeah, he says, those squirrels have been acting up. And I said, what are you doing about it? He says, well, I try to shoot them. Well, it turned out those squirrels were mistaken as, were children who were mistaken as squirrels. And so we found out that he had a dementia, and that, again, he misidentified, which is actually part of Lewy body dementia, when you start misidentifying objects and people as something else. It's somewhat delusional. You can identify that through things like social assessment. We also like to assess mobility. This is really huge. Most people, when they ask if they have a geriatric program, they say, how do you assess mobility? And they say, oh, we do the timed up and go test, or the TUG. So basically that's a test where you get up from a chair, you walk 10 feet or 3 meters, and you return to the chair and sit. And if it's more than 15 seconds, that's considered abnormal and would represent somebody who has a mobility impairment and likely to have a future fall. It turns out that you actually do a 10-meter gait speed, so 4 meters of the ones is the distance that you measure, but you give them a couple of meters before. I'm sorry, it's not the 10 meters, so the 8-meter walk test. So you give them 2 meters as lead-in, you have them walk, measure those 4 meters, and then you have a cool down or slow down another 2 meters. And actually, so slow gait speed, again, less than a meter per second, is a very strong predictor of future disability, future falls, and for future hospitalization. So, it's just amazing to me that this simple test isn't being used more generally, because if you look on medical charts, particularly like in Epic, where we use the electronic medical record, they have a risk for hospitalization scale, and it's like, I don't know, it's like 8 to 10 different elements, and they give a score, and you look at the scores like, what is the score? If somebody had a gait speed of 1 meter or less, everybody would know immediately that that person's at risk for hospitalization, and so you would take all the appropriate steps for preventing that from occurring. So anyways, it's this gait speed is so much simpler to use, and everybody understands it, as opposed to all these other elaborate risk factor devices. In terms of the musculoskeletal exam, another way to, or alternative way to assess fall risk is to do what we call the Sharpen-Romberg. So you can see in this insert here where you get both feet semi-tandem, and then finally put the left foot in front of the right foot if they happen to be right-handed. You always keep the dominant foot in the back, securing foot, and then you wait and see if they start wobbling, and be at the ready, because a lot of these people, as soon as they go into that stance, are about ready to fall, and it occurs very, very quickly within a 10-second period. You also want to measure proximal muscle weakness, so doing things like a shoulder shrug or a leg lift. I also like to test for psoas stretching, so that measures the hip extension, and you'll be amazed if you apply this to your practice as to how many people have limited flexibility in their hip extension, as reflected by a psoas spasticity. So just to summarize our comprehensive geriatric assessment, it's basically a very complete history and physical that's been expanded with various functional assessments. I think really, if you can just remember the 4 M's, I call them the geriatric 4 M's, that's going to give you the essence of geriatric assessment. So we want to know what matters so that we can align the care of the patient with their health outcome goals. We also want to look at medication for opportunities to deprescribe, and I think everybody pretty much is on board with the idea that persistent PPIs are detrimental. They're a predisposition. These proton pump inhibitors are a predisposition to osteoporosis and to future C. diff colitis if the individual is treated with antibiotics. And then the screening for mentation, that's the other 4M, looking for early cognitive impairment, which can actually be managed through adequate blood pressure control, increasing physical activity, and there's now emerging evidence that the type of diet that you have may reflect on how rapidly your cognition deteriorates. And so just Mediterranean diets seem to be protective, or omnivore diets are accelerants to dementia. And then finally, the other 4M is mobility, and the key there is to improve mobility and to prevent falls. So we just want to mention what I call the Geri Light or rapid assessment. So these all do a very quick assessment in terms of the domains of cognition, physical functionality, and psychosocial function. So I'll walk you through a few of those elements here. So the strategy for rapid screening focuses on functional status. And so remember the activities of daily living and instrumental activities of daily living. Those are now combined into one in a short questionnaire here of do you need any assistance with walking, bathing, meal preparation. So Meal on Wheels would be a meal preparation issue. Management of medications, or a big one is household finance. So again, people that are early cognitive impairment tend to have problems with either their taxes or bill payment. So mobility, you can do your own timed up and go test. I like the gait speed test, so you could either do it in feet or meters, preferably the meters. And so you convert that in. If it's less than 1 meter per second, then you know you've got a positive screen for future falls. In terms of nutrition, just simply asking or identifying the weights, consecutive weights, you can identify unintentional weight loss. The rapid screen would also include vision testing, so being able to read small print as well as achieving at least a 20/40 Snellen chart vision test. In terms of hearing, you can just simply ask the patient whether they have any hearing loss, and or you can conduct the whisper test. In terms of cognitive function, you want to do the mini-cog test. If they don't want to do the mini-cog test, you can turn and say, well, okay, let's just name me some animals. Name me some farm and jungle animals or zoo animals. And they should be able to recitate at least 12 or more animals within 60 seconds. Okay, so a lot of times you'll find people with cognitive impairment, they may repeat themselves. They'll go cat, dog, maybe zebra, and then they come back to it and they go cat. And so that redundancy and repetitiveness sometimes will be identified through what we call category fluency. If you ask somebody that's a mechanic and familiar with cars, you can ask them, name me all the different models of cars that you can think about. So, you give them the benefit of the doubt as to what they can potentially accomplish with their category or object naming. In terms of depression, I think it's pretty established that the PHQ-2 is a very quick test. This can be done by intake personnel when patients come into the clinic. It could be done by the med tech or the nurse, as well as the provider. It's a pretty simple 1-2 questionnaire here. And then we've mentioned about the rapid geriatric assessment with those different questions. There's a kind of one-stop shopping here from that's also been produced by the St. Louis University. And you can see it covers a frailty question. So this is more targeting geriatric assessment to identify what we call geriatric syndromes. Okay, so looking at frailty, sarcopenia, nutritional deficiency, and cognitive deficiency. Also added to the rapid assessment are questions about constipation, bowel problems, incontinence problems, and then also advanced directives. So in terms of looking at primary care strategies for geriatric assessment, there are different approaches. Some advocate a pre-office visit survey. If you contact the informant, there's a so-called TICS for cognitive impairment. So that's the telephone cognitive impairment test, where you ask the informant, is their spouse having any problems with memory? And that might prompt, if it's positive screen, might prompt some further testing. Again, some levels of efficiency is to add the PHQ-2 and gait speed. So that's what we're doing in our clinic to the vital sign intake. And basically, you can train different members of the staff as part of the team effort. And there's really interprofessional cross activity. So we've had pharmacists conduct mental status test exams. They do other things in terms of medication screening. The social work, for example, may do cognitive testing also. So the handoffs for each of the geriatric assessments can be done according to the person's comfort level and knowledge of conducting those tests. I just want to mention that there are telehealth options for a lot of geriatric assessment, and we've actually been piloting various geriatric telehealth encounters, and there's the option of doing telehealth geriatric assessment with a visiting nurse or caregiver. And then there's the option of doing the testing directly with the patient. And so the former encounter with when there's somebody there helping, whether it be a caregiver or a health worker, a direct healthcare worker, such as a certified nursing aide or a nurse, tends to be a little bit more strategic and valuable because they can help do things like assist with the gait speed analysis. So in your primary care practice or in your hospital practice, it's always important with each clinical encounter to identify the geriatric 4 M's. So you want to look at, again, what matters: medication, mentation, and mobility. And as you screen for these, so on the right side here with medication, you might look for opportunities to de-prescribe, and if not, to get rid of the medication entirely, then to de-escalate the dose. I just did this a couple of weeks ago with a patient who was on a massive amount of 3 SSRIs for gosh knows what, I presume depression. That wasn't clearly stated in the chart, but somebody had given this individual high-dose trazodone for sleeping, which is actually wrong. You're supposed to give low-dose trazodone for sleeping. They were on high dose and a couple of other medications, SSRIs. So they were set up for serotonergic syndrome and whatever. And so de-escalating the doses was an important accomplishment because patients get tied into their medications. They say, "Oh, my psychiatrist prescribed that to me. Don't touch it. Don't touch it." You, as primary care, have total authorization to change your consultant's medications. And as I say, if as a geriatrician, if I get spanked for de-escalating medications because it improves safety, so be it. In terms of mobility, so if somebody screens negative for fall risk, you can certainly talk to them about physical activity with the target goal of 8,000 steps daily. They should also be performing twice weekly resistance training, and that may just be simply just standing up and sitting down 10 times and repeating that 3 times. In terms of mentation, if somebody's screened positive for memory impairment, you have opportunities to talk about tighter blood pressure control, something called dual task training, where you have the individual count backwards while they're walking. That helps improve the spinal cord reflex for fall prevention. They should also engage in cognitive games and, as I mentioned, improved nutrition, leaning more towards the MIND diet or the Mediterranean diet. And then in terms of what matters, if they don't have their advanced directives, make the referral for advanced care planning. That's important, and getting that documented. So practice the 4 M's and then come up with management plans that are consistent with what matters to the patient. I just want to make a brief reference to acute functional decline. Most of functional declines in older adults is very insidious, very gradual, and you get to the point where family members and even the patient don't recognize that they've really reached some certain thresholds of frailty or what we call pre-frailty. But in terms of an illness such as acute exacerbation of heart failure with, for instance, normal systolic function or diastolic heart failure, that can really lead to a functional decline within a short period of time. And the recovery period is always a problem. So we say in geriatrics as kind of a rule of thumb, for every day in bed in the hospital, there's 3 days required of recovery. So if you figure out that somebody's in the hospital for on average 5 days length of stay, you can pretty much estimate that it's going to take them 2 weeks to recover to their pre-hospitalization status. So the important thing is that depending upon the class of or the conditions that the older adult has, so for example, with the second point of frail individuals, a third or 33% of them will acquire a new disability in the absence of any illness or injury. It just kind of comes on without warning. And so these are important. Sometimes they are precipitated by a fall, but other times you're not quite sure what led to the change in functional status. And an important element to remember is this third point, is that return of function, particularly after hospitalization, will occur within 3 to 6 months. There was a Japanese study that actually found that the cutoff was 3 months. So if you didn't recover from your disability after a 3-month period post-hospitalization, it was highly unlikely that you would recover it thereafter. So you've got a really short window of recovery, and it's so important to engage families and the patient in a very aggressive and steady and consistent rehab program. I would just say that most people who have an acute functional decline, older adults over the age of 75 in particular, barely can lift 2 pounds of weight. So that just gives you an idea of how functionally impaired they are post-hospitalization. So to summarize our geriatric assessment module here is that geriatric assessment intends to focus on functionality, so function of brain, physical function, psycho-emotional function. It's intended to promote wellness and independence of the older adult, again, trying to expand what we call healthy lifespan. Geriatric assessment is comprehensive and includes all the domains that we talked about for functionality. If the major take-home message for you from these presentations on geriatric assessment is applying the 4 M's, that would be wonderful. So with each clinical encounter, if you just write down or if you have a dot phrase that populates the electronic medical record that includes what matters, medications, mobility, and mentation, you'll be well ahead of the game in terms of working competently with the older adult in your clinical encounters. And then finally, I just want to point out here that outcomes research shows that geriatric assessment will lower acute care usage and improves the quality of healthcare. So it's that huge effort that we're trying to do where we're trying to lower costs and improve quality. So there are some resources that you can look at. So you can refer individuals to the U.S. Administration on Aging for older adult services. A lot of states have specific referral opportunities. So for instance, in North Dakota, where this talk is emanated from, the state supports what's called NDC3. So North Dakota Chronic Conditions times 3. So NDC3 is a website that allows older adults and providers to identify community-based health promotion programs. So things like silver sneakers or referrals to the Stepping On program for falls can be identified through the website. And then we have our what's called the Hersa-funded Geriatric Workforce Enhancement Program. So if you go to this website, Dakota Geriatrics, we have lots of different clinical tools, training sessions, and so forth, so you can enhance your care and assessment of the older adult. So to wrap up, I just want to add a few comments about measurement of quality of life. This often doesn't show up in our clinical programming, but I think it's important, certainly in terms of research, and if you're interested in quality improvement, doing evaluations such as the short form 36 will help assess different functionalities, including pain, social function, vitality, and all these elements that are self-reported by patients to see if your program and if you're doing geriatric assessment really has an impact on self-reported health. And this just gives you a breakdown of the different items that are associated with the SF-36. And again, this is a very good tool that you could use periodically let's say biannually, to monitor an older adult population is to see whether their perception of their health is stable, improving, or getting worse. And so that's all the roles that geriatric assessment has. And so to move the needle on the SF-36 outcome measurements would be one of the goals that we would hope to achieve if you're looking at a population health perspective for applying geriatric assessment. So that's my final slide, and I just want to point out again, referring back to Dakota Geriatrics for additional online training, and I appreciate your attention for applying geriatric assessment to your clinical everyday practice. Thank you.